Welcome to this high-yield hematology recall session where we break down the most important and tricky question asked in INI-CET and NEET PG exam. In this video, we will cover some most frequently tested topics from bleeding disorder to myeloid neoplasm and discuss related questions from the topic. Here you can clarify your misconception and use this video as a revision material. These are not only memory based question answer, we will explain the concept, give you your exam shortcut and highlight important topics for your final exam. Let's start sharpening your edge in hematology. So the first question is, what is the most common inherited bleeding disorder? Mark this word inherited. The answer is von Willebrand disease. This question may confuse you a little, so look at these facts. Overall, most common bleeding disorder is von Willebrand disease, which is mostly autosomal dominant. But when there is a word called symptomatic, the answer is Hemophilia A, which is a X-linked disease. The most common bleeding disorder is von Willebrand disease, but it mostly remains undiagnosed lifelong. Please remember this interpretation as shown, very important for your exam. When there is a question of isolated prolonged epidemiology, remember hemophilia. When there is isolated prolonged PT, remember vitamin K deficiency and warfarin toxicity. Prolonged PT and epidemiology with decreased fibrinogen and increased D-dimer is seen in DIC. Prolonged bleeding time and normal PT epidemiology, remember platelet disorder like Glanzmann thrombasthenia. Now come to the diagnosis of von Willebrand disease. Von Willebrand disease is diagnosed by the assay of von Willebrand factor antigen and histiocytin cofactor assay. Type 1 and type 3 von Willebrand disease are quantitative defect. Type 1 is antigen level below normal. This is the most common subtype, and type 3 is complete absence of von Willebrand factor. Type 2 is qualitative defect, which shows low histiocytin cofactor activity. Type 2A is loss of large multimers. Type 2B is increased affinity towards platelet causing thrombocytopenia. Type 2M is decreased functionality despite normal multimers are present. Type 2N or Normandy type is decreased factor VIII binding affinity mimics Hemophilia A. You have to remember this short table to answer all questions in the exam. Now leads to second question. Erythropoietin is useful in which of the marrow failure syndrome? The answer is myelodysplastic syndrome. So you have to know the FDA approved indication of erythropoietin. These are chronic kidney disease, especially patients of dialysis with anemia, anemia of chronic inflammation like rheumatoid arthritis, anemia in cancer patients of chemotherapy, ZWD induced anemia in HIV patients, and anemia in myelodysplastic syndrome in low risk MDS with low serum erythropoietin level. Erythropoietin stimulating agent or ESA or simply EPO remains the first line therapy in MDS. There are multiple newer drugs approved for MDS therapy now. Luspatercept, which is a activin receptor ligand trap, is useful for ringed sideroblast and MDS with SF3B1 mutation. Lenalidomide is useful in MDS 5q deletion. Low dose azacitidine may be useful in ESA refractory MDS. Combined luspatercept and ESA may be also tried. So now it's time for third question. Third question is, what is the primary site for EPO synthesis in adult? The answer is peritubular interstitial fibroblast in renal cortex. So we have to know the site for EPO production. In adulthood, 85 to 90% of erythropoietin is produced in kidney from peritubular interstitial fibroblast like cells. Another site for adult EPO production is stellate cell of liver, which contribute around 10 to 15%. Fetal yolk sac and placenta remains active in intrauterine life. Other organs like brain, testes, spleen may produce but in negligible amount. One more concept you have to know is the hypoxia and its relation to EPO synthesis. Hypoxia inducible factor or HIF remains the active in hypoxic environment to facilitate different cytokine transcription involved like erythropoiesis, angiogenesis, etc. Newer drug like roxadustat keep the HIF stable at normoxic condition and increase EPO production, which is useful in anemia due to chronic renal disease treatment. Now question number 4 asks the best immediate therapy for childhood ITP with bleeding. Answer is intravenous immunoglobulin. Now you have to know the treatment option for childhood ITP. When the platelet count is 20 to 30,000 and no associated bleeding, careful observation may be offered, as most of the cases resolve by own within 6 months. But when platelet count is below 30,000 or there is bleeding, first line treatment options are intravenous immunoglobulin, anti-D immunoglobulin, or steroid. Steroid may be oral or IV. Anti-D immunoglobulin is used rarely as nowadays, as there may be associated hemolysis. Most preferred agent is IVIG. The dose is 1 gram per kg for 1 day. Second dose may be needed if there is bleeding. Oral steroid is started with IVIG. Dose is 1 to 2 mg per kg prednisolone for 3 weeks. Then the dose is tapered. Such a high dose of steroid is often associated with toxicities like weight gain, Cushingoid fasces, bone pain, even diabetes mellitus, making the IVIG a better choice. Now remember, TPO receptor agonist like L-trombopag or romiflostim, these are indicated only in second line of therapy. These drugs are safe and associated with longer remission duration. For chronic ITP, rituximab can be used at 375 mg per meter square weekly dose for 4 weeks. Dapsone is another second line drug. Previously, splenectomy was considered as potentially curative therapy, but not nowadays, as there are very high risk of thrombosis and infectious mortality. So the last question for today's discussion is, which of the following is not an appropriate choice for Hemophilia B? The answer is cryoprecipitate. Please remember, fresh frozen plasma contain almost all plasma clotting factors. So this is the natural choice blood product. Recombinant factor 9 is the purest form and very effective in therapeutic and prophylactic use. But when inhibitor develops, means there is antibody against factor 9, recombinant factor 9 is ineffective. So some bypassing agent like recombinant factor 7 or Novo7 is useful to treat bleeding. You have to know the component of cryoprecipitate bag. It contains fibrinogen, fibronectin, factor 8, von Willebrand factor and factor 13. Per bag of cryoprecipitate contain 80 to 150 unit of factor 8, which is therapeutically useful for Hemophilia A. That's wrap the high-yield hematology recall video of INI-CET and NEET PG. You don't just give the answer, we break down the reasoning concept and the traps examiner love to set. If you find this video helpful, make sure to rewatch before exam. Remember, revision is the retention. Don't forget to like, comment your doubts and subscribe for more rapid review sessions in pathology, hematology and beyond. I am Dr. Sudeep Roy and I will see you in the next video. Until then, keep studying smart.